essentially we found a specific pathology because of a large ovarian cyst which was responsible. And what we'll do in this perspective is try to discuss about various scenarios in which different forms of this peripheral precocious puberty presents. How is it different? What sort of evaluation is required, and how do we manage about this? This was a 3-year-old girl who presented with vaginal bleeding. She had thelarchy within 2 weeks, stage 2 breast development and pubic hair, and she was not very tall in that regard. So this is a very, very unusual scenario. Normally we talk about how there is a gap of approximately 1 year between the onset of thelarchy to the progression as far as the vaginal bleeding is concerned. Now, in this scenario, what we are seeing is that there is just some breast development which has happened in the last 2 weeks. And since then, you have a vaginal bleeding, which suggests that this is an extremely hyperestrogenic state. So estrogen becomes too high, the breasts don't get time to progress, and you have got vaginal bleeding. Now, vaginal bleeding typically happens when there is a withdrawal. So usually it means that the cyst now is not forming a very high level of estrogen. So your estrogen levels are coming down, and now the bleeding happens. So this is what was assumed in this case. There were no features of cafe au lait spots or rickets, and the parameters which showed that the LH and FSH was undetectable, and estrogen levels were reasonably high at that point of time. Now, what I'm trying to say is that this is the phase when your estrogen is weaning off. So probably this is the time when this 43 estrogen, which is very high for this girl, the levels would have been even higher, going up above 100 also in many scenarios of peripheral precocious puberty. So this was a classical case, and it was found to have an ovarian cyst which was detected. Now, the big question here is what to do from here. So most of us thought that, okay, there is no other clinical features of hypothyroidism, no features of McCune Albright syndrome. So let's reassure this girl and just follow up on that perspective. But what happened that she presented a couple of years later with a trivial fall resulting in fracture, which was attributed to a fibrous dysplasia, which was developed. Now, there are no other clinical manifestations of McCune Albright at that point of time, yet she actually behaved like McCune Albright in that perspective. So this really highlights that even if you have an isolated ovarian cyst, if it's happening at a very early age, you have to think of a genetic cause. And I always say if you have a severe, syndromic, soon, or segregating etiology, these are the 4 conditions where genetic causes have to be considered. And McCune Albright is essentially a somatic disorder. And when you talk about a somatic disorder, the manifestations will depend upon how many cells are affected. So you may or may not have the entire spectrum, which is there in that perspective. So what we'll try to do over the next hour or so is try to cover 4 of very interesting cases and how they differ and make appear similar also in various perspectives to go from there. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources regarding pediatric endocrinology, including courses, online courses for fellowship and diploma programs. We do run a number of monthly programs like our lecture series for postgraduates, for grand rounds, and these programs try to cover the entirety of pediatric endocrinology over a 2 to 3 year period from that regards. Our mobile application helps guide, evaluate, assess, and manage conditions along with our publications, both basic and advanced pediatric endocrinology. And just recently, last month, we brought out this pediatric endocrinology protocols, which covers the various aspects of evaluation and management. Now, what we're going to do over the next hour or so is try to cover 4 cases. So we have got an infant with ovarian cyst, which initially Dhwani will talk about. Then we have cyst with cystic lesions, skin lesions, young girl with ovarian cyst, and finally a girl with short stature and ovarian cyst. Before we do that, we will have a look with regards to a basic understanding of what we are talking about before we go ahead deep in terms of individual cases. So when we talk about puberty, we know that there are 3 major organs which regulate the pubertal onset: the hypothalamus, which produces the GnRH, the pituitary, which produces the gonadotrophins, and the ovary, which produces the estradiol. Now, within that, we typically classify this into a central form of precocious puberty, where you have got a high level of gonadotrophins. It's more of a concordant development. Typical gap between thelarchy and vaginal bleeding is around 1.5 to 2 years. If it's less than 1 year, we start thinking that it doesn't look like a central precocity, and then mostly it's idiopathic. While peripheral precocious puberty is more like a ovarian estrogen production, characterized by hypogonadotropic scenario, low LH-FSH, discordant pattern. Like in the first case, you had got a breast development and suddenly you have got the vaginal bleeding. So if you have a history that, okay, last 1 year, there was breast development and now bleeding happens, this looks more like a central precocious puberty. If you have no breast development and you have a bleeding, this looks like a local cause. But if you have some breast development and yet you have got bleeding, this discordant pattern suggests a peripheral precocious puberty, which is usually more likely to be pathological. Now, there are various causes which can cause the central precocious puberty, which will include effects like tumor, radiation, trauma, any insult will cause that. But most of it is 95% will be idiopathic. So beyond 6 years, we do not want to do unnecessary evaluation in the form of an MRI to identify a lesion. There are rare genetic causes which may also be there in that regards. Now, what our focus is most towards this aspect of the algorithm. So we'll talk about largely about McCune Albright syndrome as a possibility. Hypothyroidism, we all know the TSH, when the levels are very high, is going to act on the FSH receptor to cause this development. Rarely you can have an estrogenic adrenal tumor, which can cause that. So within the scheme of causes of precocious puberty, we'll be focusing about the peripheral precocious puberty, which will include ovarian, and we'll focus pretty much all these three as a group. And then you can have rare scenarios like aromatase, excess, or exogenous or Peutz-Jegher syndrome as a form. So functional ovarian cyst is a very common finding, which is basically means that your dominant follicle has become bigger and it's producing estrogen, and it's usually LH independent. Now, the course is usually fluctuating and often it's a one-off phenomena. I'll talk about that as to if you have a single isolated cyst, whether you need to worry about genetic causes or not. That's an important issue. But mostly it's a single event. It will not happen repeatedly if it's just a functional cyst. And you will have a high estradiol levels, which will be there in that regard. So management largely is observation, and we'll talk about criteria when you need to worry about and when you can think of torsion or malignancy as a possibility. So a cyst which is less than 10 centimeters typically, who doesn't have a solid cystic area, does not require a surgical intervention. You can manage it conservatively. Granulosa cell tumor is exceedingly rare, but it is known to occur in children. So it's basically will have a very rapid production. Your estradiol levels will be sky high. So if you talk about a cyst, so what happened? There was a cyst, there's some bleeding, some breast development, and then regresses. Here it will be a continued process. It will continue to grow from that perspective. Your estradiol levels will be very, very high, and you will have other markers which will be produced. So if you have a granulosa cell, it's going to produce more of inhibin, AMH, all other factors will come from there. And you may also have tumor markers which are being produced. So this is more like a ovarian estrogenic tumor. Very rare, but if you have very rapid estrogenization, which is persisting, and you have a large cyst which has a solid cystic area, start worrying about this condition. Really, management, of course, is cumbersome. You will require gynecological referral, surgical intervention, and further management will come from there. Now, one important condition which we'll be discussing today is the McCune Albright syndrome, which is basically a problem in the GNAS1 region. So the GNAS is an important part as far as the cyclic AMP pathway. As far as the reproductive phenotype is concerned, this is because of overexpression or overfunction of the LH and FSH receptor, which basically will act on the ovaries to produce breast development, which will happen early, and you will have this discordant menarche level. Again, the estrogen levels will become very, very high. Importantly, because you do not have much effect as far as the adrenal axis, you will not have pubarchy. They will present purely with a vaginal bleeding and some breast development. Because of very high FSH receptor expression, you will have large ovarian cyst. And the typical pattern is that, okay, you have got development now, you have got bleeding, you see an ovarian cyst, then the ovarian cyst regresses. There is a period in which there is no significant development, and then the second cyst appears. So it's like in the somatic areas where you have a problem in the ovaries. Now, this is a somatic defect. So not the entire ovary is affected. So it's not behaving like a testotoxicosis. Now, if you talk about testotoxicosis, that is a LHCG receptor activating mutation. So the entire testis is producing a huge amount of testosterone. This is not working like a ovotoxicosis. This is like certain cells in the ovaries, certain of these oocytes or the follicular cells will be starting to become more active. And so time and again, some of them will be selected and they will start producing. So it's a off and on waxing and waning phenomena, which is common in the setting of McCune Albright syndrome. Now, TSH, of course, there are many other hormones which act through the GNAS pathway. So in TSH, it will cause thyrotoxicosis. You will have growth hormone excess causing acromegaly in certain scenarios. You may have a ACTH independent Cushing syndrome scenario. Skin lesions, of course, which are very, very important, are again because of the melanocyte stimulating hormones. So MSH hyperactivity in certain regions will cause pigmentation, and you will have bone abnormalities in the form of hypophosphatemic rickets like scenario, or you may also have a scenario of fibrous dysplasia. So the classic description of McCune Albright syndrome, which is imprinted in most of our minds, is a combination of peripheral precocious puberty along with café spots and fibrous dysplasia. Now, what you need to remember is that this is a textbook description, and in real life, the patient has not read the textbook. So they will not come to you with these three complaints that I have got McCune Albright because I have got an ovarian cyst, I have got a café spot, and I've got fibrous dysplasia. They can come with multiple varying manifestations. They may just come to you with isolated fibrous dysplasia, which is a very, very common, most common presentation, I will say. So you will have bony lesions, some bony swelling, especially in the skull areas, in the hand. There may be a trivial fracture. So you have to keep your eyes and ears open that, okay, this could be a fibrous dysplasia. Think of McCune Albright in that regards. They may present to you just with recurrent ovarian cyst, where there is no other manifestations which are present that you have to be worried about. Similarly, in scenarios like macronodular adrenal ACTH independent macronodular disease, you have to think of a possibility of McCune Albright. Any child who has got growth hormone excess, McCune Albright is a strong possibility. Any child with hypophosphatemic rickets, think of McCune Albright. So you don't need to have the entire combination. Even a single manifestation becomes important. I'll talk a bit about criteria about McCune Albright a bit later subsequently. So this is a somatic defect, variable and fluctuating course, and you may also have a secondary central precocity. Now remember, it's a defect which is there in the GNAS pathway. So what's basically happening is that your pathway continues to be active because the GTPase action is compromised. So the whole process of cyclic AMP is continuously being produced in that regards. Now this defect may not be present in the whole blood because it's a somatic one. So often most of the tests are not able to detect this, and this becomes important from that regards. What about hypothyroidism? So uncontrolled hypothyroidism will cause a very high level of TSH, which will act on the FSH receptor to cause large ovarian cyst, because there is a structural homology between the TSH, FSH, LH, HCG, and we have discussed this in many details. And this will cause large ovarian cyst. They may go up to 8 centimeters, 10 centimeters. I've seen cases who have been referred for surgical management, but then they are found to have hypothyroidism in that regards. They will have breast development. They will, of course, have vaginal bleeding, but they will have a delayed bone age because of the hypothyroidism primarily, and very importantly, because of hyperprolactinemia, they will have a low level of LH. So high apparent FSH activity, which is going to cause more ovarian stimulation, and low level of LH will basically mean that you have got no amount of pubarchy. So again, if you compare this scenario to a boy who presents to you with a severe uncontrolled hypothyroidism, they will again have the same scenario: large testis and no pubic hair. Similarly, large ovaries and no pubic hair. So effectively, von Wieck-Grumbach syndrome, as the term is called, is similar in manifestation in both boys and girls. It's just a matter of how they present. Depending upon menarche, you will get it much more easier in girls. In boys, as I said, FSH is a minor player. So high FSH will do nothing. It is not going to cause any change. It will only cause increased Sertoli cells, causing more testicular size from that regards. Again, no pubarchy is there. Rare scenario, which is similar to manifestations as far as McCune Albright is concerned, is Peutz-Jegher syndrome. It's a problem. It's considered to be a neoplastic disorder, part of endocrine neoplasia syndrome. So it's the STK11. Again, this is going to cause more cellular growth. So all of these are causing more cellular growth. Manifestations are ovarian sex steroid tumors, which may again cause precocious puberty, which will be peripheral in the form. And very importantly, you will have pigmented lesions, which are there in the mouth, like lentigens. I'll showcase one of my papers, which I've done in Australia, which showed that MAS may also have these form of lentigens, and they may also cause gastric polyps. So there is an overlap between STK11 and GNAS1. So these are like all the growth pathways which are going to be stimulated. Subsequently, we'll discuss about that. Aromatase excess, extremely rare scenario. Again, it will cause precocious puberty. You will have high levels of estrogen and you will have increased growth and bone age in that regards. Now, when should you think of a peripheral precocious puberty? So basically, if you have a very simple traffic as it's going like this, it's a concordant pattern, it's more likely to be a central precocious puberty. But if you're traveling somewhere in Kanpur or something where you find such a bizarre sort of a traffic and everybody is going here and there, you think of it's more like a peripheral. It's like a organized chaos. That's what peripheral precocious puberty is. So it's a fast and discordant pattern of peripheral precocious puberty. Of course, the most important tests are gonadotrophins, and we all talk about the importance of LH, which is much more important compared to FSH. Invariably, if you think of central precocious puberty, your LH FSH will be 0. Anybody who has a high FT4 should have a 0 TSH. Anybody whose cortisol is high should have a ACTH, which is undetectable. Similarly, if you have very high estrogen, you expect your basal LH to be less than 0.1. So generally, you are not in much doubt, but you can do a GnRH stimulation test if there is a confusion. You give a triptorelin or you give leuprolide 20 microgram per kg, 100 micrograms, and then you check your LH levels after 0, 2, and 4 hours, and you will find that there is lack of response, which will suggest that this is a peripheral precocious puberty. For me, a very high estrogen level and an undetectable LH is pretty good enough. You then have to go for imaging in that regard. So what you do is that if you have complete development and your LH is prepubertal, you have to go for peripheral precocity and go for imaging.
My case is a ovarian cyst with a girl presented with short stature. So a 7-year girl has initially presented to a GP with an off and on headache, which was initially he did a MRI and he saw a mass-like lesion in the pituitary region, for which he referred the child to the neurosurgeon. And the neurosurgeon, in the view of a ovarian function, a cyst in the ovary, he referred the child to us. So initially the girl had off and on headache associated with a menarche, which was started 3 months back. Also, the girl developed breast development 3 months ago, and the menarche was 1 month ago.
You have a girl who has got a pituitary mass and she has developed menarche. So your diagnosis is there. This is clearly a central precocious.
So we have to go further to evaluate this case,
so
whether is
would be the usual pubertal manifestation of a pituitary adenoma. What happens to puberty in pituitary adenoma? Suppose, assuming this was the pituitary adenoma, what is your pattern? Suppose this was the gonadotropin producing adenoma, will it cause precocious puberty?
No, sir. This will not cause because
suppose it's producing LHF, so why will it not cause puberty? Why? So that's why the key principle is, if you see pituitary adenoma in a girl with precocious puberty, it is not the cause, it's an incidental lesion. So even though the neurosurgeon is thinking there's a pituitary mass which is producing gonadotropins, causing ovarian cyst, causing precocious puberty, that's not the case, and we'll see what the cause subsequently from that other angle. Yeah. And again, this discordance is very, very evident in this case.
Now, the child had a very short height, but the weight was on the normal side, clearly showing that this is a case of an endocrinal type of a short stature. The breast was well developed, breast stage 4. There is no pubic hair development, and menarche has already been started. So there are two things in our hand. That is, one is the short stature, and the girl has presented with a precocious puberty, which is a discordant one. Now this is the picture of this girl, which clearly shows a breast stage of 4.
No pubic hair.
No pubic hair is present. Investigation.
So what are you thinking now? You're linking up ovarian cyst, short stature, precocious puberty, and a pituitary mass.
So this has a thing that this is a case of peripheral precocious puberty, first of all, because there is a discordance in the presentation of breast development and menarche, and associated with the short stature. So differential like hypothyroidism will be there in our possibility. There will be one possibility. McCune Albright can also present, but the age is very.
You have to link with the mass. How do you link mass with hypothyroidism?
Hypothyroidism can also be cause a pituitary hypoplasia like picture, because of this low level of thyroxine. There will be increase in the thyrotrope releasing hormone, which acts on the pituitary lactotrope and somatotropes, causing this pituitary hyperplasia like picture.
So that is very, very important. And McCune Albright, you can't think of suddenly somebody comes to you at 7 years of age with this short height. Clearly, this will be a case of hypothyroidism. Now, McCune Albright, can it cause a pituitary mass? It can cause a somatotrop hyperplasia, but usually it will not be that big. Thyrotrop hyperplasia is very big, but somatotrop hyperplasia, you will have so many features of acromegaly or growth hormone excess by that time. So that is a theoretical thing, but this is classically, I think this is a scenario you can blindly say this is hypothyroidism, a large mass, and every year we see 2-3 cases like this who are referred to neurosurgeons, referred to gynecologists. So large mass, ovarian mass, pituitary mass, and short stature, precocious puberty. This is hypothyroidism, which you will see on the workup as well, I think.
We worked up on the basis of the short stature, and the routine workup was absolutely normal, except from the thyroid profile, which shows a TSH level of more than 100. And also we have started then with the basis of the high TSH level, we started the patient on the thyroxine 75 microgram. So if we gather together all these things in the table, that there is precocious puberty, which is a peripheral one, there is a hypothyroidism, and also there is a pituitary hyperplasia like picture. So this clearly indicates a diagnosis towards the Van Wyk-Grumbach syndrome. Now, regarding the history, this thing was initially diagnosed in 1905 by Dr. F.W. Kendall, who diagnosed this in a 9-year-old girl child who has a prominent features of severe hypothyroidism. But to surprise Dr. Kendall, there was also precocious puberty instead of a delayed puberty, which he has reported in his case report. And
in fact, there are reports even from 1800s, 1850, 70, which talk about that. So when the original word was coined, they mentioned it is 100-year-old at that time. But unfortunately, still we are seeing cases which is extremely unfortunate. Yes, and then even then they are missed. So this is something which is known to the medical literature for such a long time.
And the term was actually coined in 1960, so late in the
paper, they talk about 100 years from then. Okay. So it is like such a old scenario. And
now,
they used to give
thyroxine extract from the ships, they had used in that patient.
Grams and other quantity.
Now, regarding the pathogenesis, as Sarah has already described, that these glycoprotein hormones like TSH, LH, and FSH and HCG had a similar alpha subunit and a difference in the beta subunit. This similar alpha subunit causing this high TSH to act on the FSH receptor to form this ovarian cyst-like picture. There is, due to this ovarian cyst, there is increased estrogen production, and this estrogen production is causing this thelarche and menarche. As there was puberty is stimulated by another axis, the ACTH axis, there is no usual puberty present in this case. Now, why is this case is different from another other cases? Because usually we see that in hypothyroidism, the puberty is usually delayed. But in our case, the puberty is usually precocious due to the FSH receptor action on the TSH. There is, in the precocious puberty, the bone age is usually advanced, but in this case, the bone age is usually delayed. And in precocious puberty, we also know that there is presence of sparse hair presentation, But there are many case reports which have seen there is hypertrichosis that is associated with this case. Now a case report which showing a male child who presented with this peripheral precocious like picture, the large testicular volume with large testicular volume, but there was hypertrichosis that is seen in this picture present in the back and the facial region, and they have having a case report like that.
So we have discussed 4 very, very interesting cases, 2 of very early onset ovarian cyst, 1 which turned out to be McCune Albright like, and second which was functional. A second one which was basically in the form of hypothyroidism, and another scenario in which you have a functional cyst. So how do we manage peripheral precocious puberty? We already discussed. If you're thinking of McCune Albright, use aromatase inhibitors, use selective estrogen receptor modulators, estrogen receptor antagonist. Hypothyroidism, if you treat with thyroid replacement, the cyst will regress, they will improve. You may have to give a course of progesterone because they may have uncontrolled bleeding. Once you treat hypothyroidism, their estrogen levels will fall and their bleeding may become very severe at that point of time. High dose of progesterone may be required. And usually for ovarian cyst, unless it's larger than 10 centimeters, unless you have got other markers of malignancies, tumor markers, solid areas, you don't need to worry about, and just observe in that regard. So we'll now close, and you can all going to have a look at our website and the courses app and books in that regards. We'll quickly look at if there are any particular questions which are there. So I think there are a few. So does genetic test confirmed MAS? In this case, we did not go for the genetic test because there was no cutaneous tissue and the ovarian cyst, it would have been difficult to extract fluid from there. Peripheral blood, 20 to 30% only cases are there. So if you have many manifestations, you are more likely to pick up on the peripheral blood. Dr. Choman is asking, in some cases of untreated, undiagnosed peripheral precocious puberty, it may trigger central system as well. How can we diagnose the primary pathology and how can we treat? This is a very, very interesting question. This is much more common in boys as against girls. And girls, of course, the history is so obvious, you will not miss it. So if a girl has bleeding at 1 or 2 years, they will immediately come to you. But often with CAH, the simple virilizing form, the presentation is so gradual that they will not come to you at that time. So it's much more common in boys. But if you have a doubt, if there's again a discordant history, which is that will give you like a peripheral, and then if it's triggered, of course, still you will have some evidence of a primary pathology. It most often happens with McCune Albright. Of course, functional ovarian cyst and hypothyroidism will not trigger because in those scenarios, the bone age is not advanced.